So let me go over some of these aspects perhaps in more detail, and let's add some other elements. With respect to the antibiotic therapy, the choice is important. We mentioned should be broad spectrum because we want the antibiotic therapy to cover for all possible microorganisms. If we want to be a little bit more selective, we need to consider the source of infection when we know about it. We need to consider the type of pathogen that the patient may already have if the patient has been in the hospital, or the type of microorganisms that we are likely to find in our community, in our hospital, in our environment. And there are also some patient-related factors. Some patients are immunocompromised and may be infected with less common microorganisms. Some patients may be debilitated because of alcoholism or malnutrition or other factors. And the patient may have been in the hospital for several days, and then we need to actually more seriously consider multi-resistant pathogens. So, as I said before, later on, after a few days, we may consider decreasing the spectrum of the antibiotic therapy. For how long should we treat? Usually 7 to 10 days. Now, if you measure CRP, C-reactive protein, or procalcitonin, you may consider the decline in these levels over time, together with the clinical evaluation, to better decide when to stop the antibiotic therapy. If the patient improves quickly, and if the CRP levels or the procalcitonin levels go down quickly, maybe 5 days, sometimes 4 days may be sufficient. So that's important if we want to limit the risks of even more resistant organisms. With respect to fluid administration, it is the fluid challenge technique which is recommended. We give 100 to 200 cc's of crystalloids over a 10-minute period, not more, and we evaluate the patient's response. We may also use albumin, especially when patients have received already some amount of crystalloids. We should not give too much saline, especially if the chloride levels increase in the blood. Then it's the right time to replace saline solutions by what we call balanced solutions, having other electrolytes, such as the Ringer's lactate solution that we sometimes call the Hartmann solution, or Plasmalite, for instance. Now, there are some techniques proposed to evaluate fluid responsiveness. Can the patient respond to fluids? It works only in a minority of cases, especially if you look at pulse pressure variation. The patients must be mechanically ventilated and sedated. Passive leg raising is a technique which may work, but it's not so easily performed. You need to measure stroke volume accurately because the changes in stroke volume will be very transient. Usually we use transesophageal Doppler for this, but not just blood pressure. No. Be careful. So signs of fluid responsiveness, it's okay, but it's only in a minority of cases, and if you know how to do it. I spoke about the repeated lactate levels over time, the SCVO2. These are important complement variables to the clinical evaluation. With respect to the other elements, mechanical ventilation, as always, we should limit tidal volume, always. Whenever we use mechanical ventilation, even for surgery for a few hours, we need to limit the tidal volume to 5-6 cc's per kilogram. There is nothing magic with the number, but we need to use small tidal volumes, not 9-10 cc's per kilogram. And we should probably avoid excessive FiO2s, excessive oxygen concentration. Don't look for an SpO2 of 100% when we have the signal available, of course, when the patient is not in deep shock. Then we try to have an SpO2 of 93, 95, 97%, not higher than that, because there is some evidence that hyperoxia may be harmful. Do not sedate the patient. Why? No, especially if there is shock, we should avoid all sedative agents that could further alter the hemodynamic status of the patient. Whether you use benzodiazepines or propofol or even dexmedetomidine, they can all alter the hemodynamic status. Do not use bicarbonate unless there is profound acidemia. Sometimes in cirrhotic patients we have very low pHs, but otherwise, just with hyperventilation induced by mechanical ventilation, we can keep the pH at about 7.3 or a little above, and there is no need for bicarbonate administration. Finally, nutrition. There is no urgency, especially if there is shock. We can wait until the patient is stabilized. We can wait 1-2 days if needed. Then, if possible, we start enteral nutrition. There is no need to start parenteral nutrition right away unless the patient is malnourished. But if the patient is not malnourished, we can wait for several days before we start parenteral nutrition. We usually start parenteral nutrition after 5 to 7 days when needed, because there is a good study showing that if you start it early, it may be worse. So there is really no urgency. I forgot to mention 2 things. One, no routine place for immunoglobulins. No evidence. And second, steroids. Corticosteroids. Aha! Yeah, there may be a place for hydrocortisone at a dose of 200 milligrams per day. It could be 4 times 50 milligrams IV, but only in severe shock states. That is, when the patient is on relatively high doses of noradrenaline, maybe more than 0.5 microgram per kilogram per minute. Maybe above 35, 40 micrograms per minute. Then you can start it for the duration of shock, for a few days if needed, and then we stop it. We can stop it abruptly. There is a recent study which was presented at our symposium in Brussels a couple of months ago, a study from France, showing that this can decrease mortality rates. So it adds to the previous controversy, corticosteroids, yes or no. In the Surviving Sepsis Campaign guidelines, we say, well, yeah, but only in severe cases. Yes, this is supported by the recent evidence. So there are quite a few things to be done. We may need a team to do that, not just one doctor and one nurse. We may need a few doctors, a few nurses. We need to constitute a team in our hospital, not only at 10 o'clock in the morning when we can find enough people around, but also at 3 o'clock in the morning or on a Sunday afternoon. It's important to find enough people to do all this rapidly, as time matters if we want to treat these patients early and effectively to prevent complications.